So that covers when do we do it. I think it helps to put things in perspective when you're doing clinical exam. We talk about why do we do it, when should we do it, when should we not do it. I hope that, help you plan it. And now I think the meat of the presentation is how do we do it? Okay, how do we do it? I think that's what you will want me to talk about. How do I make a temporary implant crown? So I'm going to follow this sequence. And this sequence is an article that I quoted, also written by Dr. Stephen Chu, because I think it helps you to understand the steps taken for something of this protocol. Okay. So everyone's just think about, oh yeah, just remove the tooth, place the implant, and then make a temporary crown. But just like when you do your crown, when you do your bridge, before you pick up your handpiece, you have to have a plan how to make your temporary, right? So it may be, you may decide to do a chair side, do an impression of the tooth before you prep it, but there are times the tooth is missing or partly gone. So how do you plan so that on the day of the surgery, you know how to make your temporary crown? So in this particular article, Dr. Stephen Chu talked about taking an alginate impression and using that impression to make a shell of acrylic out of the tooth. Okay, so this is something that you can certainly consider doing it. So you just take an impression of the tooth before it's extracted. And what you would do is you use traditional jet or PMMA material where there's liquid monomer and powder polymer. And this is actually a very classic way of doing things. So if you were practicing prosto in the 80s and 90s, this is your basic skill set. You would have a sable brush where you would just dip in the monomer and pick up a bead of the polymer and paint it on the tooth where you want it. So you just wanted to make a shell of the particular tooth that you're going to make a temporary crown. Okay, so you just use this brush and dip it into this the monomer and the powder, pick up a bead of powder, go around this wherever the tooth you wanted to make a temporary until you have essentially you're going to make a blob of a tooth. Once it's set, you tease it out and then you core out the inside, or maybe you finish it up so that here in the article, they suggest you to make a big hole on the occlusal surface or the lingual surface, because that's going to help you make your temporary implant restoration later on. But this is a step that was recommended by Dr. Stephen Chu's article. And I find that a lot of people actually, even in the Toronto setting, not a lot of people know how to use this material anymore, but I show it just for historical reasons, so you know where it came from. So Dr. Chu in his article talked about using this to make a shell of a temporary crown to be ready to be used for making the temporary before you extract the tooth. Alternatively, you can use the patient's extracted tooth, like the one that I show you from Dr. Wong's case. You can definitely use the tooth and core it out and connect it to make a temporary crown. Okay, so my point is, before you start extracting the tooth, you have to have a plan. So just like when you're doing a crown or bridge, you don't want to start filing the tooth and then you realize you didn't have an impression or a shell, or maybe you decide just to do a block 10, which is fine, but you need to have a plan to make to make your temporary implant crown. What I usually do is, before I do anything, I just take a sectional impression of the area, and I use bite registration material, which tends to set a lot faster than traditional impression. But it just gives me a mold of the particular tooth that I'm going to make a temporary crown. Okay. If the tooth is missing to begin with, you may have to do a little bit of prep work, where you might have to, take the impression, wax up the tooth, duplicate it, and make sure you have an index, whether it's a vacuum form matrix or a putty index of some sort. Okay, I'm just showing you, these are the prep work that you often have to think about if you are going to make an implant, immediate implant temporary crown. Okay, so let's suppose that you already have a plan, whether it's using the patient's tooth or you take an alginate and follow Dr. Steven Chu's protocol to do a paint in acrylic resin shell, or you take an sectional impression like I do, or you do a wax up and make sure you have something ready to go, then you can consider extracting the tooth. Okay, the idea is you don't want to start extracting the tooth and not have a plan to make it temporary. Now, extracting the tooth, I'm not going to go in a lot of details, but the idea is you want it to be as atraumatic as possible. You want to preserve the bone. You don't want to luxate the tooth and break your buccal bone. Remember, you want to preserve the buccal bone, right? So certain strategies that people have talked about is you luxate it mesiodistally, never buccolingually. You might want to section the root mesiodistally and luxate the root tip out, because you want to preserve the soft tissue and hard tissue contour. Other strategies you might have learned is just use of endophile to retrieve your broken roots so that you don't have to start digging around the soft and hard tissue. Okay, so basically, one of the key thing is to try to remove the root as atraumatically as possible so you preserve the bone and soft tissue. Once you removed it, then extra step you need to do is you wanted to clean out the socket, make sure there's no granulation tissue, and check to make sure you have the buccal plate. You want to make sure that you have at least a buccal bone 4 millimeter apical from the ideal free gingival margin. Okay, so obviously once you extract the tooth, you use the correct to, if there's any granulation tissue, remove it so it's sound bone. You might want to just rinse out all the debris inside and use a perio probe to determine where the buccal bone plate is. And you need to make sure, you know, that you have the buccal plate is about 4 millimeter away from the gingival margin. Assuming you like where this gingival margin is, you just want to sound the bone and see where that bony buccal plate is. If it's too deep, then you don't have the buccal plate, and you might decide that you want to stage it, graft it, or you might have to use the membrane to graft some bone in that area. Okay, because if you don't have the bone, your soft tissue is not going to support it, and you might have a non-ideal aesthetic outcome of the case. Okay, you may have the bone to place it, you may have the primary stability, but in order to have the stability of the soft and hard tissue, you need the buccal plate at 4 millimeter apical to the gingival margin. Okay. So once you've determined you have the buccal plate, you can do the implant placement. Obviously, you're going to place the implant in the most ideal prosthetically driven position. And so a couple of strategies that I know of is you need to engage and go beyond the root apex in order to get primary stability. That's usually the strategy. You want to go longer implant to have apical engagement. Usually I also want to make sure I engage the palatal bone. That's how I learned. Always feel the palatal bone. And if you're going to consider immediate, you should plan an implant that is long enough to engage the apical aspect of this bone. You want to make sure you're placing it in still three-dimensionally restorable way. So make sure you know where the positions are. And it's easy to get primary stability, but then I've seen so many implants where they're placed, but they're not prosthetically driven. They've gone too buccal because they went into engage this buccal bone, this palatal bone, so it's going too buccal. So while you have an implant that has primary stability, prosthetically, it's not ideal. Also, I know that if you use a denser bone drill, that's another way to get the bone to be dense, and so you get primary stability. So like again, if you remember from my last presentation, I also place implants, although I don't usually teach about placing implants, but I just want to share some strategies I know of when it comes to immediate implant placement so that you can get primary stability. Okay, so once you position it and you get primary stability, you're happy with the position, that's really when you can start making the implant crown. Okay, so the components you need to get are what we call usually temporary abutments. If it's a single unit, you need to make sure that it's a hex abutment, so it has anti-rotational element to it. I talk a lot about that in my other course. Understanding these components sometimes takes some time to digest. So, but one of the things that you will see that a lot of these temporary abutments, some of them are tooth color, some of them are titanium, and they're not all made equal. Okay, my experience is that once I order it, I look at the surface design. You can see these ones have a lot more mechanical retention, a lot more grooves. And because your temporary material is going to, most of the time, adhere to this by mechanical retention, especially titanium, okay? So when I look at these titanium implant temporary abutments, I thought these surfaces are not rough enough. And the first time I used this, I was right. The acrylic actually debonded on me. So sometimes I intentionally create more slots and holes inside these abutments so that the material can lock in a little bit better. Sometimes I don't need to do that. They work really well. So what I'm saying is every brand, every implant company will come up with some temporary abutments. Some of them are tooth color. Some of them are titanium based. But I always make an effort sometimes just to look at the surface design, because most of the temporary are locked into by mechanical retention. So if I don't like how they look very smooth to me. Sometimes before I even start, I roughen quite a bit because it gets really bloody and contaminated once in the mouth. So I want to do this once and then once and for all, and I don't want to go back and add and adjust. So one of the things I've learned is that, the first one I made many years ago, it debonded on me the next day. So I learned that just because it was made as a temporary doesn't mean it has the right surface characterization for mechanical retention. So oftentimes I will go back and just drill into these surfaces and make holes to create more mechanical slots and holes. Okay, so these are just samples that I'm showing you. You can use a tooth color temporary abutment. I find that most of the time I just use the metal ones. I can most of the time find that I can hide enough of it. It's not an issue, but obviously with a tooth color one, you don't have to worry about the color showing through as much. But just showing you these two are side by side. This is a Strawman temporary abutment, and this is Above Horizon temporary abutment. You can see the surface structure are different. And so I find that the one with Above Horizon, even you see a lot of surface texture, it's too shallow. It's too shallow that I often find that I have to go in and roughen the surface because the acrylic is not going to adhere to that very well. Okay, so one of the ways is you use the patient's tooth. You have to core out the tooth so that you can position it over the implant. Okay, so in this case, you kind of have to put the temporary implant abutment on the implant and core out the inside of the tooth such that you can position it where it looks reasonably acceptable to you and the patient. And basically, you just add some composite resin to this so that it adheres to it. On the inside surface of the tooth, you might have to etch and put some prime and bond so that it adheres to it. Okay. The idea is you just want to position it in the mouth so it looks reasonably well. You don't have to do the rest of it outside the mouth. Inside the mouth. So once you have it secure, then you can remove it, and then outside the mouth, you can finish it off, fill in all the voids, and create a nice smooth surface. Now you can look at this, you can see this nice smooth surface. The idea is to create this emergence profile that's going to support the soft tissue. I'm going to talk a little bit about how this should be. Is it, other than it being smooth, should it be convex, concave? So I'm going to talk a little bit about that because there are different opinions, and I'll share with you what I think it should be. One of the key things I've seen is there is a finish margin on the temporary abutment. You have to know how to read that. So you want to add enough acrylic or composite resin, but you have to trim it back so it's nice and smooth. You don't want to have extra one kind of going beyond that. If you do, you might not be able to see this crown, and also might cause soft tissue and bony tissue irritation because you will have too much resin that is interfering with this abutment implant interface. Okay, now this is not a single tooth implant, but this is the case that I actually documented to show you the steps what I'm doing. This is not immediate, just so that you know. The implant was already placed, but I'm going back to making a temporary. So one of the things, when you put that into the mouth, you will find that these prefabricated temporary abutments are way too long, way too long. It interferes with the occlusion. You cannot see the matrix properly. So one of the things that you have to do is to reduce the abutment until the matrix can seat properly and it doesn't interfere occlusion. Okay. Now, when you have to reduce it, you can either reduce it intraorally with lots of irrigation or extraorally. Okay. I find that if I'm not doing immediate placement, I find that it's faster for me to reduce it intraorally. But if you've never done it, it may scare you because it can create a lot of sparks, okay? And so that's why you need lots of irrigation to keep things cool. And if you want, if it makes you more comfortable, you might just want to mark it with a Sharpie marker where it needs to be reduced, remove it, and then reduce it extraorally and put it back, make sure you have in and out. I find the in and out slows me down significantly. So you'll find that I usually just do it intraorally. But when you do it intraorally, it does make it a little bit messy because you can see a lot of the metal bits and pieces that can get stuck in the area. So I don't recommend doing it if you are doing it immediate because you need the socket to be not have all these pieces here. Like I said, this is not an immediate case, but I just happen to be making a temporary crown, and so I can document the steps. Okay, so if you have to reduce it extraorally, it makes you comfortable, then do it. Okay, if you do it intraorally, just beware there's sparks and water, and it can be quite messy. Okay, when you have when you're ready to make the temporary, once you've reduced it, there's a couple of key things I wanted to tell you to do. One thing is that when I look at the adjacent teeth, if teeth are very bulbous, there's a black triangles undercut here. I usually like to block out this area so the acrylic doesn't get stuck. And the easiest way to do it is just put a cotton pallet there. So you can see that I put a cotton pallet here so that my acrylic doesn't go into this space, because I've done it too many times without it, it gets stuck. And it's okay, I can always retrieve it. But it just, if you've never done it, I think some people will get scared because they cannot retrieve it. So my recommendation is put a cotton pallet underneath the adjacent teeth so things don't get stuck. The other thing you have to make sure you do is you cover the access hole with cotton pallet. You don't want the acrylic flowing right into it because you need to be able to access the screw to remove it. Okay, so once you reduce the temporary abutment adequately, you put the cotton pallet to seal the access hole. You put cotton pallet in areas where you think it's going to get blocked out. And you want to make sure that the index it's seated properly. Okay, at this point, I want to rinse out all the debris here, make sure that this surface is not moist. This surface is dry, so it can adhere to the surface of the abutment. And so now, you know, once you get the implant abutment ready, that's where whatever you did, whatever matrix you had done, or the shell of acrylic, then you can load it up with acrylic, okay, or jet or PMMA, whatever you want to do, just like making a temporary crown, a temporary bridge, the same goes. So you want to position it back in the mouth. Okay, so you load it with the acrylic, you position it back in the mouth in the same way. Now, this is where I feel that people don't reduce their abutment enough. They can't see, and so they position it incorrectly. So this is where errors can happen, okay? So that's why every step is so critical. You want to make sure you reduce the abutment adequately. If you have a matrix that is clear, then you can see it where it's fully seated. If you have a shell, then you can also see it. So depending on which method of provisionalization you choose, it's built in some possible errors that you have to encounter. But the idea is you want to just to have some acrylic to be connected to the abutment. Okay, so this is just an example what I did of that same case. Okay, you can see that I just have enough acrylic to be connected to the temporary abutment. You can see that it picked up the cotton pellet. You can see that this is properly the proximal contact because I have the cotton pellet. It didn't get stuck in there. I have it connected, which I'm going to separate as the two individual temporary implant crown. This implant was more buccally placed, so I have to go in to screw to drill through the acrylic to identify the access hole to remove the cotton pellet in order to access the screws, so I can remove this altogether. Okay, so this is also where I find that people get stuck because they have too much acrylic or they don't know where to drill through to get the access. So some of the strategies you wanted to make sure you put enough cotton pellet or maybe even taller just so that it comes through so you can see it. It's only a thin of acrylic, a ring of acrylic that you need to drill through to get through the cotton pellet and the screws. So it doesn't look very pretty right now, but that's where, you know, the work starts outside the mouth. Once it's outside the mouth, the first thing you need to do is connect that temporary with I usually have an analog ready because it helps me hold this temporary crown better. And basically I connect this abutment to the analog to help me hold this whole piece. Then I just add flowable resin all the way to this finish line. And I start shaping this to make it look like a tooth. So you can see this is a finished product. This patient has worn this for about several months already, and you can see that the stain, everything, but you can literally see where I added and where it was. And so that's how I make a temporary implant crown. This is the other unit. I separated. So this is a Straumann implant where, you know, this is the cotton pellet that got picked up. And because it picked up that cotton pellet, it didn't get stuck. If I didn't put a cotton pellet, this temporary might get stuck and you might have to drill through the interproximal in order to get it removed. So sometimes that's not very fun to do. But basically, I just connect it with an analog and then I flow resin, composite resin, and just shape it so it's nice and smooth. Make sure it goes to the finish line, not beyond, and then it's nice and smooth. Okay, so when you put this back on, a couple of things I wanted to mention is the idea of doing that is to allow you to have soft tissue conditioning. So like I said, this is not a very beautiful case, but it just helped me show you the steps. And so this patient has two implants. This is a Straumann implant. This is a Bar Horizon implant. And I just wanted to show you, you know, I want to make this temporary crown so I can develop the soft tissue contour as ideally as possible. And so sometimes even if I do it, I don't always get ideal soft tissue, but it's a method to give you soft tissue seal and also to start developing the contour that you want to develop the contour for. So a couple of things I want to talk about is that some people talk about this gingival emergence profile should be concave rather than convex. Okay, most of the people talk about that this should be concave because it allows more soft tissue to fill into. So this is concave. This is convex. You can see the blanching of the tissue. Okay, so basically, this is the healed site. You can see that the soft tissue here has filled into here a lot better. Have I made it too convex, I might not have the room for the soft tissue to fill in. Okay, you can see even between these two implants, I didn't get complete soft tissue fill. I won't because I knowing the biology, but at least I'm trying to develop a little bit more of a natural soft tissue contour. Okay, the idea of making the temporary implant crown, even if it's not immediate place, it allows you to develop the soft tissue shape to make your permanent restoration a little bit better. Okay, so once you have this patient wearing the temporary crown properly, when you remove it, you get this soft tissue flare. What it does, it allows you, so this is an implant crown that is for this site. It allows you to make what we call a customized impression coping. So this is just an open tray impression coping, but what I did is I customized it so the gingival contour helps to support this soft tissue. So when I take the impression, it's recorded. Okay, that's another reason why for my anterior implant case, even if I'm not doing immediate protocol, routinely I make a temporary implant crown to condition the soft tissue first before I take impression, because it allows me to develop this proper soft tissue contour. It also allows me to talk more objectively with the patient, what's achievable, what's not. And so it's a step towards starting to manage the patient's expectation so they know what's feasible and what's not. And at the time of the impression, it allows me to customize the impression coping. So I record that information for the lab. So the lab will produce something that will resemble this contour rather than the contour that is arbitrarily built in, whether it may be too fat or too narrow. Okay. At the end of the day, whether it's an implant immediate protocol or at second stage, you have a temporary implant crown. For a single unit, it's usually a hex abutment. So it has built-in anti-rotational element. It needs to be smooth. Okay. Usually you have no occlusion on this temporary, eccentric or excursive. Okay. Some people will go as far as saying you shouldn't have any proximal contact, but to me, that seems to encourage fluid impaction, and that can affect soft tissue health. So I tend to have a light proximal contact because I want to minimize fluid impaction. Okay. At the end of this whole exercise, your provisional restoration should have the tooth in the form that it replaced the tooth. The emergence profile should be supportive of the soft tissue. So it looks like it's supporting the soft tissue and not making it too bulbous or too under contour. The tooth must be in infraocclusion, so it should not be in direct occlusal contact with the adjacent teeth or the opposing occlusion. And that's very important for immediate protocol. Okay. So once you've placed you've made your temporary implant crown, you're going to, you have to do that first. Okay, and then they talk about placing the bone grafting material into the space so you can put the implant crown back on there. Okay, now I want to talk a little bit about the integral surface. Like I said, you will find that a lot of people say that it needs to be concave, but I find that in some cases I need to make it convex because it all depends on the position of the implant. And sometimes if the implant is not placed in the most ideal way, for whatever reason, this is where the emergence profile of my temporary implant crown needs to be contoured to support the soft tissue to provide them optimal aesthetics. Okay, basically, two rules I want you to remember. If you make it more concave, like how I am showing it here, which is what most people say, most of your emergence profiles should be concave so you have more soft tissue to support the area. And this is also, that's going to affect where the gingival margin needs to be. So if you do develop it more concave, the gingival margin will tend to come down occlusally. If you make it too convex, you tend to push the soft tissue up and above, and you may push it too gingivally, too apically, which may be aesthetically not ideal. So I want to share this detail with you guys because when you, even if you don't make the temporary crown, if you get the lab to make it, they might shape it in a way that might not support the soft tissue because they don't really see the soft tissue response like you do. So this is a case I just want to share with you. This patient, as you can see, in the 2-1 has external root resorption. This was initially planned for extraction, immediate placement, and immediate provisionalization. But we didn't end up doing immediate provisionalization because the periodontist felt that it was a very tough extraction and maybe it doesn't have the ideal primary stability. So we ended up just letting this heal, and I ended up just giving the patient an Essex for the time being. However, when the implant has healed properly and I got the go-ahead from the periodontist to make the definitive restoration, because it's an anterior case, I don't jump to the direct final restoration. I actually make a temporary implant crown first. So in this case, I actually digitally scan the case. So you can see this is the scan body. I scan it and I had the lab make it. I just didn't have the time to make it chair side. I thought the lab can make it nice and pretty. And so this is the temporary implant abutment. It's going to show up radiolucent because this is a temporary material. But you can see that there's blanching, and at the time when I inserted it, you can see that I didn't like the gingival margin that kind of pushed it too high. So it's too convex the way the lab made it. Okay, so I chair side reduce the convexity of the contour of the emergence profile to make it a little bit more concave. And so this is how the tissue looks. Okay, so I brought it down, you can see it, but not completely down. But you can see by just manipulating the gingival emergence profile of the temporary crown, you actually can alter how the tissue will look. So that's why I actually believe that in some ways, you know, whether it should be concave or convex, it depends on the position of the implant. And sometimes you have to understand how this is shaped can influence the soft tissue contour. Okay, so I'm just showing you a couple of examples of the temporary implant crown I did for the patient. These are all chair side, didn't have the lab to make it. And so idea is to provide the most natural gingival shape of the implant for the implant restoration. Okay, so this is an implant temporary crown, this is a temporary implant crown, this is a temporary implant crown. And when you remove that temporary implant crown, you can see the soft tissue flare. Some are much more flare than others, depending on the size of the tooth, the contour of the tooth. But what it does now allow me to do is it allows me to customize the impression coping. Okay, it allows me to customize the impression coping so the lab has the more knowledge about the soft tissue contour that it needs to be shaped for your final definitive restoration. Okay, so for these cases, these are the customized impression coping. Basically, it's just impression coping where there's a ring of acrylic kind of wrapped around the impression coping to support the soft tissue. So when you take the impression, it registers the shape of the soft tissue you wanted the lab to build to. Okay, so when you take the impression, when you remove it, you can see the gingival contour of these impression because it captured that information, and the model would have that defined shape so the lab can make the temporary or the definitive implant restoration with the more ideal emergence profile. Okay. So these are just some of the anterior cases, you know, that I did. So this is the implant. This is an implant. This, I end up doing two crowns. This is a natural tooth, and this is an implant crown. And so this is just one implant. Okay. So I'm going to just finish this presentation by talking about the steps for customizing the impression coping. Okay. So basically, the whole point of making a temporary implant crown, first, if you're doing immediate protocol, is it offers you an opportunity to restore aesthetics and also to do a soft tissue seal for the bone grafting. Even if you're not doing immediate implant protocol, my anterior implant crowns always have a temporary because it allows me to shape the soft tissue the way I want it. It allows the soft tissue to heal around it and allows me to talk to the patient what's feasible, what's not feasible. And once the soft tissue heals properly, then I can make an impression by customizing my impression coping. Okay, so these are the steps that I take. And so I'm going to go step by step how to do that. Okay, now, before I go any further, my original presentation talked about all these methods. You can go direct or you can go indirect. Okay, my preferred way is going indirect open tray technique. That's what I do, and that's what I'm going to show you. But that's not the only way to do it. And if you look at implant companies' catalog, they will show you some of the direct methods. In another presentation, I talk about their pros and cons, but I don't have the time today to talk about it. So I skip all that. So basically, what I'm doing is I'm just talking about the indirect open tray technique. Okay. So let's suppose then this is a patient with an implant with a temporary, okay? You can see that I lost some soft tissue, but I still made it doesn't have the ideal interdental papilla. There was some soft tissue trauma to that area. I had to do a lot of bone grafting in the area, but anyways, I was able to make a temporary implant crown for him and let the soft tissue heal. So this is where, you have a patient with temporary crown already. And the first step is to remove that temporary implant crown. You remove that temporary implant crown and connect it with an analog. Okay. So what essentially you're trying to do is you wanted to capture the gingival emergence profile of the temporary and capture that. So with this temporary crown with an analog, usually I will make a mold of this area. So to do this quickly, I usually have a medicine cup ready, and I usually use by registration material to make the mold because it sets fast. And so this is what I would do. So you can see that I just use a medicine cup. I inject a mountain of by registration material. This is just blue mousse. And before it sets, I embed the whole thing, the temporary crown and the analog, inside to this mountain of registration material before it sets. I want to make sure that the registration material captures the gingival emergence profile of my implant crown. It doesn't have to embed this whole crown entirely. In fact, if you do too much of it, it's harder to remove it. But I just want to capture the gingival's emergence profile of this implant crown with the analog connected to it. Once it's set, you will remove this implant crown. Okay, so this is another case similarly. You have the patient with a temporary, the soft tissue has healed, the temporary crown is now connected to the analog. You inject here, they're just using heavy body impression material. I use by registration material because it sets faster. Before it sets, you just embed the whole bottom portion, including the analog and the bottom half of the temporary implant crown. You let it set. Once it's set, you remove the temporary crown. What you're going to see is you're going to see the implant analog embedded inside to this impression material. And also you have captured the emergence profile of the temporary crown. Okay. So remove the implant crown from the analog. Okay. And then you see that you have the analog inside there. Now you just take an open tray impression coping connected to this analog. What you will see is you got a space here. That emergence profile that you have created, there's a space now. So this space is what you're going to fill this up with either flowable resin or self-curing resin. Okay. So I usually use flowable resin, but you can also use GC resin that sets fairly quickly. Once it's completely set, then you can remove that and trim any excess flash. Okay, so this is just showing you the case that I did. I put an impression coping there, and the space that was left between the temporary crown, I fill it up with flowable resin. Once I fill it up with flowable resin, remove it and make sure it's smooth. I want to make sure that if I put it into the implant, it's not touching on the adjacent teeth. So if you do too much of it, you have to trim this back. And so that's how you make a customized impression coping that follows the contour of your temporary implant crown. Okay, so make an impression of the implant crown with the analog, remove that, put the impression coping, fill this up with flowable resin, and then remove any flash, any sharp edges. Then you can put this onto the implant, take an x-ray, and that's how you take an impression. When you take an impression, when you remove it, basically you capture the gingival emergence profile of the implant where you have conditioned it using your temporary implant crown. Okay, so this is just showing you a couple of different cases I've done. This is, you know, the case where I had the temporary implant crown, then I customized the impression coping. This is now depending on what material you use, when you take the x-ray, sometimes it will show up, sometimes it doesn't show up. If you use GC resin, it's going to show up radiolucent. Here I probably use a radial opaque form of flowable resin, so you can see the little flare on the impression coping. Okay, and when you take that out, you can see the gingival emergence profile. Then so when the lab pours it up, it captures that information accurately. Okay, so this is another case with the impression coping that's customized and what it would look like on the integral surface after the impression has been taken. This is just showing you when you use GC resin, when you take an impression, it's going to show up radiolucent. It doesn't mean you don't have it. It's just beware of that because it's GC resin, it's radiolucent on the x-ray. Okay. So this is just showing you the implant that's placed. That this was removed, it was bone grafted, it was placed, and then I think I added a tooth to it. At the time, I didn't provisionalize at the same time, but when I did provisionalize it, okay, you can see the composite resin to provide better soft tissue contour. And then when I take the final impression, it's not going to show up on the radiograph because I use GC resin, which is radiolucent, and then the final restoration of the implant and the natural tooth. Okay. So just be aware the radiographic appearance of your customized impression coping depends on the material you use. For GC resin, it's going to show up radiolucent. For if you use composite resin, then it might show up as radial opaque. Okay. So this is the temporary implant crown that I made for this patient. It's showing up as radial opaque. The actual customized impression coping, I don't think I have a picture of it, but it just shows you, you can see the ring of composite resin around my impression coping. Okay. So these are some of the anterior implant cases I did. For someone who has that this, I didn't plan it, but the patient came already with the implant placed. So I always make a temporary implant crown. As you can see, the color isn't perfect. And then once I make the temporary implant crown, I customize it at the time of the impression. So then the lab can make the soft tissue contour as best as possible to match the patient's existing gum contour. Okay, so again, you make the impression with the temporary implant crown. You remove it and put an impression coping and just flow some resin around it, or GC resin, trim the excess, make sure it doesn't touch the adjacent teeth. And then you take an impression. And that's how you do customized impression coping using the patient's temporary crown. Okay, the key is to make sure that you position it adequately so you can retrieve the screw. One thing I wanted to mention is you can see that a lot of my cases I use custom tray, and custom tray costs more money and time. I see some of my colleagues and students want to just use stock tray. Stock trays, you might get away with it, but there are times when I try to do that, I'll share with you the challenges. With a custom tray, it customized to the patient's unique arch shape. It allows you to provide an even space of material for the impression material. It also customizes the opening so it's easy for you to access the screw. Because I like to do open tray, I find that it's more accurate in my hands. I tend to use a custom tray. But the disadvantage of that it adds to your lab cost. It takes time to fabricate. But the problem I find when you're using stock tray is sometimes the stock tray is shaped in such a way that the screw is not long enough for me to retrieve it, or the stock tray may be impinging on the vestibule, so I cannot position it the most ideal way, leaving that I have too little material in some areas. I might not be able to retrieve the screw easily. Okay, so this is a case that I thought, oh, this patient has a fairly standard shape of the arch. I could get away with just using stock tray. I create an opening, and I had when I took it, it took me by surprise because the screw was not long enough. So I have to, at the time when I take the impression, I have to wipe enough material so I can see this access hole. So what does it mean? It means I might have too thin of material, so it might not be as accurate. And the other thing is I was trying to push it down more so I can get more of this screw exposed, and I was hitting the patient's lingual tori, and so it was hurting her. So in this case, even though I thought it was a standard case, a single tooth implant, I was lazy. I didn't prepare a custom tray, but these are the challenges I find myself facing whenever I use a stock tray. So when you're taking impression with implant where you're doing an indirect open tray, it's critical that you need to position it ideally so you can retrieve the screw. And so by doing a custom tray, I find that it eliminates all these problems. Okay. So that's all. I think I've covered a lot of things today on single anterior missing tooth, specifically talking about the immediate implant protocol. And if you are going to plan on making temporary implant crown for the aesthetic zone, what to consider and what challenges you may face and why we're doing it all together. The key thing is if it's part of your immediate protocol, it offers a soft tissue seal for the bone grafting material. So there is a biological reason. It restores the aesthetics. It's just better patient acceptance. But if you end up staging your anterior implant, just you didn't do implant placement immediately, you went back to bone grafting, whatever. For me, when the case is ready for restoration, I still make a temporary implant crown for the patient first, whether chair side or you take an impression, because it allows me to condition the soft tissue, allows me to customize the impression coping, and allows me to manage the patient's expectation in terms of the contour, what's possible, where the gingival margin is there a black triangle that you should anticipate, and things like that. I find that for a single anterior missing tooth, because it's very aesthetically driven, patient does have high expectation. And by implementing these steps, I find that I have better outcome in terms of the patient's expectation and also the soft tissue contour. Okay, so why do we do the immediate implant protocol? It restores the aesthetics. There's a biological reason for bone grafting. It preserves the soft tissue, and also you get better patient acceptance, but it's not for everyone. Okay, you can only consider that if you can have primary stability, if the implant can be positioned in the most correct prosthetically driven position, and that you have buccal plate to work with. Okay, you have to have an ideal local bone defect that shows favorable morphology for you to consider that. Okay, and keep in mind of the patient factors. Not everyone is suited for that. If they have thin gingiva, they are high risk. Patients with existing infection, the heavy smoker, those are cases I would be a little bit cautious, or I have to manage the expectation that I might still not get an ideal outcome, even if everything had gone smoothly from the surgical aspect. The patient's factor, the healing potential, sometimes can compromise the outcome as well. Okay, so this was supposed to be the summary of my last lecture. We talked about implant treatment planning, consideration, the roadmap you need to consider very quickly last week. We also talked about the treatment execution phase, specifically the delivering consideration for single tooth implant. And today I really just talk about the single anterior solution, talking specifically about how to make the temporary implant crown, the why, and the how. And I hope that you found this presentation useful. Okay, how am I doing with my time? I'm good, right? You're muted.
Yeah, I said we're very good with the time, and just wanted to find out if there's any questions. I know this is probably new for most folks. I don't know if anybody has ever. Is anyone here who has tried to make a temp before? I mean, most people are learning to place implants the first time, so I think this would be a very good reference material. Can we use, there's a question here that says, can we use custom abutment in single implant immediate case?
We use
like placing the implant. The question, well, the question says, can we use a custom abutment in an immediate implant case?
Well, I guess your custom abutment, by virtue of a custom abutment, you can customize it by the lab, right? They most of the time either cast it or mill it, right? So for an immediate implant case, I find that you can plan it, and you can plan and have a custom abutment made in advance. But I think that's, the lab will try to do that because the lab will make money off that. But logistically, I feel that I'm wasting money if it didn't go all smoothly. There's a lot of things on my end that I feel like, okay, so if the implant is in place, because of whatever reason I can't get primary stability, and you have this custom abutment that is not used, and maybe you can reuse it at the time of uncovery. Okay, so I guess you can, but most of the time we provisionalize it at the time because we can customize it chair side, right? So the fact that if you're going to plan a custom abutment for a single immediate implant case, if you ask the lab to do it for you, yeah, they'll do it. They'll just charge you for it. But that's extra labor because you're customizing it, right? So I guess the short answer is yes, but why would you do it unless you have a lot of money to waste?
All right. Anyway, I mean, thank you so much. This has been, I'm telling you, this is one of the most valuable lectures in the series that we've had. We've been doing this for many months. So yours is very practical. You can watch it and do it, and you can, I mean, so many things to learn. There's so many terminologies in terms of materials and all that, in terms of the things we have available. But hopefully, we are going to hold on to this for a long time. There is a question here. It says, can an immediate implant protocol be ideal for patients with uncontrolled systemic disease?
Yeah, no, I
I
wouldn't.
mean, implant
So
itself, implants.
implants itself for uncontrolled systemic disease shouldn't be. The patient should have control disease first. Like I find if you have a diabetic who's not controlled, wound healing is going to be compromised, even if you do everything ideal. And if the patient factor is not working for you, then the outcome will be less ideal, right? Not as predictable. So it's not indicated for uncontrolled systemic disease.
Okay. All right. Thank you. Thank you so much, Dr. Leong. And hopefully, so this class, the group of participants, this is their last week. They've been on this for 8 weeks. And I believe, I know, I guess they will agree, they've learned a lot, and the videos are always there for them to go back to. And obviously, we also have some materials online. But thank you so much for giving us this this part of your weekend. We truly appreciate your sacrifice.
Well, thank you for the opportunity. I hope everyone will find something